Zolbetuximab is a Claudin 18.2 specific monoclonal antibody which can induce the nausea and vomiting as an on-target toxicity because Claudin 18.2 is also expressed in normal gastric mucosal cells. And actually during the phase 3 trial, we observed a 16% patient with any grade nausea and 50% with vomiting. So to manage this kind of toxicity is very important in clinical practice if the drug is approved. So in this ASCO GI, we present a characteristic of this nausea and vomiting and efficacy of management. And actually, this nausea and vomiting usually occurred during the first infusion, and the median time for occurrence is around one hour. And these events are clearly decreasing at subsequent cycles. Firstly, we compare the patient who requires a dose interruption during the infusion by toxicity and the patient who can continue the treatment. And there is a difference of initial rate of infusion. So higher or faster infusion at the beginning seem to be more likely to induce nausea and vomiting. So in the current recommendation or guidance for management, there is a recommendation to start a slower infusion at the beginning, and if tolerable, we can speed up the infusion time. And this seems to be nice based on this kind of analysis. And next, we analyze type of antiemetics and exact frequency of nausea and vomiting. There's no clear trend, but most of the patients received a 5-HT3 inhibitor, and half of the patients received the NK1 inhibitor, and 40% patients received the corticosteroid. And here there is some trend of somehow reduced incidence of vomiting in patients who received multiple antiemetics like 5-HT3 with NK1 inhibitor with or without corticosteroid. So not clear, but some trend to reduce the nausea and vomiting by these antiemetics. And finally, we also evaluate prognosis or PFS and OS in patients with or without use of corticosteroid. Because in protocol, use of corticosteroid is not recommended, but not prohibited because of some concern of decreased activity by ADCC and CDC. Actually, 40% of patients used or received steroid. And here we observed no detrimental or negative effect of steroid use in terms of benefit of zolbetuximab in PFS and overall survival. So overall, these results suggest that some management caveat like a slower infusion at the beginning and the use of antiemetics. And if needed, we can use corticosteroid, which cannot negatively affect the treatment outcome.